Okay. So this is what I'm going to cover today. The strengths and limitations of molecular diagnosis, applications to the diagnosis of graft dysfunction, and its potential use in risk stratification. So let me put the subject of molecular diagnosis in perspective. Examining organs must be a hierarchical process. Gross evaluation is a key first step. We all know, for example, if an organ is not sliced thinly enough, if we don't identify a graft, if we don't make sure that it goes into the paraffin block, no molecular diagnostic technique is going to give you the correct diagnosis. So next step after the gross is the light microscopy, which extends our resolution to maybe about 0.04 millimeters. Then we have EM resolution, which takes you to about 0.1 nanometers. And the sampling becomes even more critical when you go to that high a power. We have immunohistochemistry, which allows identification of specific proteins. In situ hybridization gets you to the DNA and RNA molecules. And then we should correlate all that information with proteomics, genomics, transcriptomics that allow us molecular level observations. But you cannot and should not start at the bottom. You will come up with often a very misleading answer. There are some indispensable strengths of histologic examination, which we must always remember and be proud of, no matter what modern techniques are coming. It's histology which provides structural context to molecular findings. It can identify the gross topographical regions that are involved. Some diseases affect the cortex, like rejection. Others affect the medulla, like pyelonephritis. Histology localizes the disease to specific microcompartments. Glomerular diseases like FSGS, tubular diseases like polyoma virus, interstitial diseases like IFTA, vascular diseases like graft arteriosclerosis. So this information can only come from a biopsy examined by a pathologist. Histology tells you the cell type affected. For example, proximal tubular vascularization will tell you its cyclosporine toxicity. There's no molecular test for that. Electron microscopy can go to the subcellular organelle level, such as, for example, mitochondriopathies instead of a toxicity. Histology has additional relevance to transplant pathology. It gives you a very quick turnaround, as little as 4 hours. It can identify diseases with non-viable tissue from which you're not going to get any RNA out. It recognizes scars, which again will be transcriptionally inactive. It allows visualization of rare lesions, such as intimal arteritis, even if it's present in 1 out of 10 arteries. And it permits the use of several ancillary techniques. There are problems in histology. It can be subjective. Sometimes it applies arbitrary rules. For example, 4 lymphocytes per cross-section make it borderline and 5 make it mild. That's really sometimes not even appropriate. It is semi-quantitative in nature. It gives you grades 0, 1, 2, 3, and grade 2 can be as low as 26% area. It can be as high as 50. There are reproducibility issues, although I must say that happens when you have too many grades. Everybody can distinguish mild rejection from severe rejection, but the interface between borderline and mild can be problematic, but it's also less critical. If you take the clinical picture into account, it's not that big a deal. So there are a number of novel approaches to molecular diagnosis of renal transplant biopsies. There is morphometry with or without in situ hybridization. You can analyze pixel data with artificial intelligence and machine learning. You have quantitative PCR, you have nanostring technology, there's digital spatial profiling, there's RNA-seq. I cannot cover all that. I'm not an expert, nor do I have the time. So what I will do today is focus at the lowest item, which is the DNA microarray technology. And I will focus almost exclusively on the MMDX system, the so-called molecular microscope, because that is the system for which we have the largest amount of human biopsy data. And yes, this technology offers us many advantages. It can allow objective quantitation instead of semi-quantitative grades, ideally of the severity of rejection. also of the magnitude of tubular injury, although there's more work to be done in this area. It can interrogate biopsies at the molecular level. It can show you changes at the biochemical level, which are not even seen by light microscopy. It can profile the phenomena which go on with tissue repair, development of tolerance. You can assay thousands of genes, come up with diagnostic classifiers, prognostic classifiers. It can give you mechanistic insights, such as we now understand the role of NK cells in antibody-mediated rejection. So these are the diseases I'll cover from the point of view of molecular diagnosis. Please note the abbreviations, which I'll be using throughout the talk. ABMR, antibody-mediated rejection; BL, borderline change; TCMR, T-cell mediated rejection; V lesion, which is the same as intimal arteritis; and BKV nephropathy, BKVN. So let's start with the antibody-mediated rejection. This is a classical study from the Halloran group. They started out with 65 ABMR biopsies, and they compared them with 338, which could have any other diagnosis. The top 20 differentially expressed genes were used to build a linear discriminant analysis classifier. The output of this classifier is a score from 0 to 1, which reflects the probability of the diagnosis of ABMR. And they used a score of 0.2 as the cutoff for ABMR, yes or no. And they chose it because it corresponded to approximately 90% specificity of the diagnosis that they were being made in the histologic examination. And these are the parameters they use for training this classifier. G greater than 0, BTC greater than 1, CG greater than 0 were all acceptable. C4D could be 0 or 1 or 2 or 3 if the DSA was positive. And of course, we must recognize that inter-observer disagreements in the histologic scoring, especially of low-grade lesions like glomerulonitis and PTC, are rather high, maybe in some studies 35 to 45% range. So we must always recognize that these molecular classifiers have been benchmarked against low reproducibility lesions. Therefore, they cannot inherently be regarded as superior to that histology. So if you have to show that molecular interpretation is superior to histology, you need an independent validation without using the histology. And that can come from clinical parameters. And unfortunately, that's a lot of work still to be done in that area. Here's an example of the molecular ABMR scores in one of the INTERCOM studies. Can you see my arrow? Let me see if I can turn my pointer on. Okay. All right. So this is the threshold for ABMR, yes or no. And yes, the majority of C4D positive and C4D negative ABMRs can be recognized quite well by this classifier. You would also notice that about 10 or 20% of the TCMR cases, they have high ABMR scores. And certainly there may be cases where these are ABMRs recognized by the molecular diagnosis, but not recognized by histology. That is certainly an area where these tests can help. But we must also remember other possibilities. Some of these could be complement negative, independent, or ABMR, or they could even be non-ABMR endothelial injury. And similarly, some of these cases may be HLA antibody independent ABMR. So this is a summary of how the classifier performs in ABMR. The specificity was 87%, negative predictive value was 94%. There was a 67% sensitivity for the local diagnosis of ABMR or mixed. In other words, 1/3 of the cases which were being recognized by histology were not being called ABMR by molecular diagnostics. And I believe it's partially an issue of sampling and focal distribution of the lesions, and that's why histology remains important. The positive predictive value for ABMR was only 50%. Now, the 50% which histology called ABMR, the molecular diagnosis did not, they were unfortunately not analyzed in great detail. Was it because their G and PTC scores were not high enough? Did they have non-HLA antibodies? So these are areas where we need better and more systematic studies to understand where and why these discrepancies occur. And for sure, molecular diagnostic cannot replace the histologic diagnosis. It cannot tell you there are thrombi or V lesions or severe transplant glomerulopathy, or the fact there is 50% glomerular sclerosis, or the fact that there might be advanced IFTA. Molecular diagnosis will fail if there are QC parameters, if the tissue is infarcted. It may not generate enough signals if there's dense fibrosis. It does not identify ABMR mimics, such as membranoproliferative GN, thrombotic angiopathy, ANCA vasculitis. However, it can certainly play a complementary role to histology, and it would be particularly useful, for example, in biopsies which have equivocal glomerulitis or peritubular capillaritis. There are lesions where we struggle. Is it 0? Is it 1? The molecular diagnosis could help. It could help biopsies where the G and PTC sum score is 2 or 3, but the C4D is negative. In fact, this technology has helped us realize how often we do get C4D negative ABMR. And then we can use biopsies which have definite G and PTC lesion and C4D, but the DSA negative. And in many areas of the world, the DSA is not available. So yes, in these areas, these tests can be helpful. This test could be helpful in biopsies which are just C4D positive and do not have any histologic evidence of rejection with or without DSA. So these are the areas where this technology could be an asset and a complementary role to histologic examination. Let's move to borderline change. As you know, this is very briefly stated TCMR, which does not meet the criteria of BAMF1A. So I will leave it at that for simplicity. There are problems with these calls. There's difficulty in grading information, especially there's an imprecise threshold between what's I0, what's I1. There's no attempt to make a case for how dense the inflammation is, and a very wide range of inflammation from 11% to 100% can fit into a diagnosis of borderline. It's very, very heterogeneous. So the molecular diagnosis has potential in these borderline cases. For example, it could quantify inflammation, perhaps more accurately than our scores, 0, 1, 2, 3. It could differentiate between quiescent and immunological infiltrates, but this is still a potential which is yet to be fully realized. And there are 3 caveats which I will go through: the sampling problem, the precision of the measurements, and some conceptual issues with using classifiers. So here's the sampling problem. Dr. Swarnalata already showed you how in some biopsies, different parts of the core can look very different. Sometimes one biopsy is not even kidney. It could be fibrocollagenous tissue, it could be skeletal muscle, it could be skin. And so if you do blind molecular diagnostics, you take a fragment off, obviously there'll be times you'll be completely off. And this could happen, in my judgment, in 10 or 20% of the time. And the question of precision, how accurate are these measurements? Here is some data where the TCMR score was plotted, the median and the interquartile range, over about 100 iterations of the scoring process. And you can see that there are at least some samples where the lower estimate and the upper estimate, they are 3 to 5 deciles different. This is not much different from, for example, BKV PCR. We know that 3 to 5-fold variations in plasma viral load are not always reproducible. So in my opinion, we need more molecular diagnostic work to determine the precision of these scores. Can these scores really differentiate between I0 and I1, I1 and I2? I hope they can, but I'm not sure. And the data to convince me is not yet there. Now, there are also some conceptual issues with applying these classifiers to human biopsies. So here's a discrepancy paper published by the Halloran group. In those biopsies which were histologically called, 128 of them, we call them borderline. In 56% of them, molecular diagnostics said, oh, this is no TCMR. But I think this is essentially a training problem. The molecular classifier was taught not to recognize anything less than 1A as TCMR. So that's what you expect. The diagnostic classifier is going to say they're not TCMR. This surprise to me is not why 56% are not called TCMR, but why are those other 44% being called TCMR when the classifier was taught to not recognize any of them? And so of the borderline cases, 18% were called ABMR, 7% were TCMR, 3% were probable TCMR. The clinical outcome of these cases, which apparently were missed by histology, is not available. And that's a problem with all of the molecular diagnostic discrepancies. The calls are different, but we do not know if they are more correct. And in virtually all of the papers, there is no clinical information to tell you whether the call is really correct or not correct. Although I would use both these pieces of information together with the clinical picture when I'm managing any particular case. But I will not always say, because the molecular diagnosis says this, therefore I'm going to let it override the histology. So let's talk of definite TCMR, one grade above the borderline. Here again, the classifier sensitivity was just 50%, positive predictive value was only 62%, negative predictive value was 92%, but pathologists can also are very good at saying there's no TCMR. The overall accuracy was stated to be 89%, but was driven largely by the negative predictive value. And again, lots of discrepancies when you compare molecular and diagnostics and histology. Only 40% of histologic TCMR was confirmed to be molecular TCMR. It is unlikely that most of these are histology false positives. I mean, come on, we've been diagnosing TCMR by biopsies for the past 30 years. And we know most of our calls are corroborated clinically by response to steroids. So I think these are molecular diagnostic false negativities due to sampling tissues. TCMR is known to be a focal process, so it's not a surprise that if you take a piece for molecular diagnosis, it may not have inflammation or tubulitis and vice versa. Some of them may be due to C4d negative mixed TCMR. Some of the discrepancies may be due to V lesions. On the contrary side, 40% of molecular TCMRs were only 40% would recognize histologic TCMRs. And there, I think some of the pathologists are at fault because historically, many IFTA lesions have not been called rejection. Only lately, we've started calling them chronic active TCMR. So I think this is an area where molecular diagnostics help us to improve histologic interpretation and help us refine our understanding of the biopsy changes. There are some limitations inherent in the so-called process of machine learning classifier development, especially referring to MMDX. No clinically validated reference standard was used when these tests were developed. They used biopsy reports, not even biopsy review, the biopsy reports from 10 different medical centers. Clinically adjudicated cases would have been better. The borderline cases, the mixed cases, the isolated V lesions were always assumed to be not rejection when the classifiers were developed, even though most clinicians know that a good proportion of these people respond to treatment. And that itself, in my opinion, accounts for 50% of the discrepancies. So I believe we need better classifiers to develop more accurate and relevant MMDX tests. Let's talk of chronic active TCMR. It was in 2017 that BAM finally recognized its existence in the interstitial compartment. And to me, that was a very puzzling denial of a very basic immunologic process as to why you can't have chronic active TCMR in the interstitial compartment. And I won't go through the criteria. Dr. Swarnalata has already gone through them. There is a lot of molecular diagnostic support that chronic active TCMR exists. For example, in the Scripps Clinic, they had studied 81 biopsies of IFTA with acute rejection, IFTA with inflammation not amounting to acute rejection, the type which was ignored by pathologists and not called acute rejection, and then IFTA without inflammation. So the IFTA with definite rejection shared about 70% of the genes with IFTA that had inflammation but didn't fulfill the criteria for acute rejection of BAMF criteria. And the expression of acute rejection genes did correlate with 5-year graft loss. So the conclusion was that many biopsies which are labeled simply as IFTA are actually chronic active TCMR. So this concept of chronic active TCMR is now accepted by most medical centers. But surprisingly, the MMDX group still does not recognize it. Here's a paper from 2019. It says, we conclude that IFTA in indication biopsies reflects recent ongoing parenchymal injury often with concomitant ABMR, but few with TCMR. I think there are problems with this reasoning. The TCMR signature was defined in non-scarred biopsies. Now, if you're going to use it to probe scarred biopsies, your genes are going to get diluted by genes of fibrogenesis, atrophy, arteriosclerosis, tissue remodeling. And also the molecular classifiers used to define ABMR was developed using biopsies, which many of us would call mixed TCMR ABR because they have inflammation and tubulitis. So there was a significant discounting of TCMR in that classifier. And that's why they claim to see mixed rejection in only 5% of cases, whereas 70% of the ABMRs we see in Pittsburgh, we think they're mixed. And this is an illustration of how molecular classifiers really reflect the opinion of the person who trained them. You can do 1,000 bootstraps, you can do ensembles of 100 different algorithms, but you cannot correct for that bias. What does the person who has developed the classifier thinks the biopsy means? Let's talk of V lesions. You all know about intimal arteritis. Let me quickly summarize the outcome. If you have a grade 2 intimal arteritis, 52 to 80% respond to anti-rejection treatment. For grade B, the proportion responding is 10%. Similarly, the difference is in death-censored graft survival. So what we call BAF grade 2 is actually a heterogeneous lesion, and its remission rates overlap with grade 1A and 1B. Sometimes you have intimal arteritis where there's just a lymph or two in the biopsy, and the rest of the biopsy is clean. So we don't expect that to do as badly as another biopsy, which is blue and also has arteritis. And there's also value to classifying the cause of the arteritis. TCMR arteritis accounts for maybe only about 20% of all arteritis, and there's a 15% graft loss there in this Paris study. Although in addition to the graft loss, I suspect there are many other cases which have low GFR, what we call impending graft loss, which is not quantified. ABMR arteritis accounts for maybe 75% of all biopsies, and rate of graft loss is high, about 60%. But we must remember, even this ABMR arteritis, if we do immunohistochemistry, there are T cell presence, not only in the artery, but also in the interstitium. So a lot of biopsies simply called ABMR are actually mixed, and calling them ABMR runs the risk of their not getting T cell therapy. And so what are the molecular diagnostic findings in V lesions? Here's a series of 30 biopsies, all from the Halloran group. They were reported as histologic TCMR. 1/2 were called non-TCMR. 17% were called ABMR, the V lesions. Half of them were DSA negative. The C4D status was not given in this particular study. For isolated V lesions, 46% did not were called actually ABMR, but they did not behave as ABMR, as most clinicians recognize ABMR. I mean, in fact, the study itself said that the clinical course of these cases were rather good. So I think the value of the molecular diagnostic scores that are being put out needs a little more validation. In some cases, I think the score is so sensitive that it has the risk of letting people get treated unnecessarily. So we definitely need more studies here, recognizing the potential of these molecular tests to diagnose ABMR when histology can't diagnose it. And similarly, it said that 43% of all isolated V lesions were no molecular TCMR. But to me, this is again a circular reasoning. The TCMR classifier was developed on biopsies like this, with a lot of inflammation and tubulitis and damage. So obviously, you can't expect the classifier to call this TCMR when it's just an isolated arterial inflammation with not much inflammation and tubulitis. And I personally think a lot of the MMDX literature on arteritis, I don't even know what it means, because it's very likely the small piece of tissue that was taken for MMDX probably didn't even have the V lesion. So these are examples, I think, of over-interpreting molecular diagnostics. So let's talk of, whenever I give a talk, I try to bring BKD nephropathy into the picture. So that's what I'm going to do now. This is the MMDX analysis of some BKV nephropathy lesions, 13. This is the TCMR score. Of course, most of the biopsies, at least half of them, would have a high TCMR score above the threshold of 0.2. Interestingly, 8 of 13 BKV nephropathies also had a high TCMR score. And so the MMDX interpretation of this finding is that most biopsies with polyomavirus nephropathy have T-cell mediated rejection. But once again, I will remind you that the TCMR classifier was never developed or validated for its ability to discriminate infection from rejection. There is no evidence actually that the biology of T-cell responses to viral antigens is any different from the T-cell responses to HLA antigens. So this, I believe, is another statement which is an overinterpretation of data. There have been other groups, such as the Serval lab, which has claimed that there are some genes which are selectively upregulated in BKV nephropathy and some which are selectively upregulated in rejection. The problem has been that they have not been replicated. These findings are not replicated either in Pittsburgh or even from the Alberta group. And I think it's likely due to the variation in inflammation, tubulitis, and interstitial fibrosis that was present in these biopsies. And there are shared pathways, of course, as I mentioned. So why is it so difficult to build a molecular classifier for BKV nephropathy? There's just actually a paper out which claims to have a classifier, but it's not really a simple interpretation. And why is that? Well, BKV nephropathy has a very range of morphologies. You can have silent inclusions, you can have acute tubular necrosis, you can have interstitial nephritis, you can have advanced fibrosis and tubular atrophy. So obviously the gene expression patterns for all these biopsies is going to be very different. So enabling a machine to learn all these patterns, I think, is going to require a few hundred biopsies. And most studies don't reach that level. So to get those few hundred biopsies, to let the machine recognize all these variations, we need all classes of disease, A1, B1, B2, B3, C, with ABMR, without ABMR, varying degrees of injury, inflammation, fibrosis. But the studies of that rigor have not yet been done. So I do not believe actually that there is a good test available out there as of today. Now, I am being asked to develop recommendations for the molecular diagnosis of BKV nephropathy by the Transplantation Society. And this is some of the things I want to say. Tissue DNA and RNA load is subject to the same sampling error as immunohistology. And I think we saw examples of that already. The TCMR molecular classifier should not be used to differentiate between cognate T-cell responses to viral antigens from allo antigens. There is no proof that this test can reliably distinguish the two. No molecular diagnostic test available today, contrary to any claims, can assess the relative contributions of viral versus rejection-associated injury. These two processes are so closely interlinked that it's very difficult to separate them. And there is no machine learning or gene expression profiling test available which can rule in or rule out what we call presumptive nephropathy. Plasma PCR is still the best way to diagnose and treat those cases. So I will briefly mention some studies in acute kidney injury. Again, from the Halloran's group, there is a study where they had 28 biopsies with ATN graded by histology. They were able to find so-called injury repair response transcripts, or IRATs. It's also called acute kidney injury. These were done by finding out the fold chain and finding the top 30 expressed genes. Yes, they had known acute kidney injury markers like CXCL1 and THSB1, but there were some other well-known markers like UMOD and FAP-B1, which were not present in the molecular tests, or rather they were present but didn't correlate with the IRAT score. And then there were some markers which were missed, like KIM1 and IL-18, although these cells did correlate with the AKI phenotype. So again, it points to using multiple approaches to probe human diseases. These are the clinical correlates for the acute tubular injury score. They were able to use it to separate acute kidney injury from normal by an AUC of 0.7. They were able to obtain a negative correlation coefficient between the scores and the GFR at the time of the biopsy, and also the change in GFR measured 6 months later. And yes, there were no correlations between IRAT and histology. I believe acute tubular injury is an area where pathologists are not very good. And I believe this is an area where we can develop molecular tests, but again, we need to make sure they are properly clinically validated. So gene expression profiles can also have prognostic value. Here's a study from the Paris group. They had cases of ABMR, a discovery group, as well as a validation group. And they found that, for example, the clinical parameters such as proteinuria and GFR had a poor correlation with the antibody scores, which is not surprising, but these are signs of chronic disease, and these are acute scores. There was also a bad correlation between histology and the ABMR score, 0.03, 0.1. For DSA, it was better, 0.4. C4D score was better, like 0.3. And of course, the ABMR score will correspond to the molecular diagnosis. These were high scores because they are interlinked scores. One depends on the other. And here's the multivariate analysis of graft loss. Donor A60 was able to get a hazard ratio of graft loss of 3.84. The sum of all the antibody scores histology was only 1.43. Molecular ABMR score was 2.22, endothelial score was 3.02. So I'm not surprised that molecular diagnosis has value, but to say that it's more than histology is not proven by this study. A lot of histology prognostic parameters, total inflammation, IFTA, chronic interstitial fibrosis, they were not even presented. So we ultimately need a combination of histology and molecular diagnostics to get the best prognostic indices for our patients. And the additive value of this molecular analysis was actually the AUC statistics increased from 0.77 to 0.81. So this was a modest increase. And we also have to think, especially in developing countries, what is the cost effectiveness of obtaining this modest increase with rather expensive tests? There are some other studies, I think, which I can skip very quickly. They tried to correlate 6-week protocol biopsy gene expression profiles with subsequent outcome. They were not successful, even though these genes have achieved success in diagnosing ABMR and in making molecular risk classifiers, which illustrates the fact that the functional significance of the same mRNA molecule can vary depending on what clinical setting you test it in. And so I'm going to start summarizing my talk here. There is no question that molecular diagnostics can take interrogations beyond the human eye. Areas of particular utility are C4D negative rejection, DSA negative rejection, IFTA lesions. No question, molecular diagnosis can recognize changes in acute tubular injury, which the human eye cannot. Yes, you can use thousands of gene readings to develop much better diagnostic and prognostic classifiers. We can predict outcomes beyond clinical parameters. We already have achieved a lot of mechanistic insights by the studies that have been performed. They could help better quantify lesions, but the application of this area needs more studies of the precision of the measurement. And then there are problematic areas which are never emphasized by anybody, certainly not by the people who give the MMDX talks. MMDX can be misleading. It can be incorrect. If you have early disease, focal disease, or if you are only biopsying a small fragment. The marketing in this area is aggressive. There are hyperbolic claims. People get up and say, this technique is 99% precise. And I just look up and say, what? Are they speaking at a scientific meeting, or is this a commercial sales talk? There's exaggerated superiority over existing diagnostic and prognostic tools. Yes, they do better, but not dramatically better. So we must read the literature carefully. We must distinguish between opinions and rigorous conclusions, which can be defended by all the variables that affect the interpretation of these assays. We must recognize leaps of logic and circular reasoning in some of the justifications that they offer. Some of the tests are valid, some are way overclaimed. And I should also note that the molecular signatures of many diseases remains to be thoroughly studied, including pyelonephritis, which was shown, diabetic nephropathy, glomerulonephritis, calcineurin toxicity, thrombotic angiopathy. And here I think there is an opportunity and a challenge for the younger generation who is listening to me today is for you to carry the field forward while senior people like me enter the evening of their lives. And so I began with the Cathedral of Learning at Pittsburgh. I'm going to end with it. This is actually an Indian nationality room. It's a functional classroom. It has been modeled after our Nalanda University. You see there's a courtyard, and these are living quarters. These are columns which replicate some of the monuments that were found in the University of Nalanda. And I will end there for any questions. Thank you very much.